is here from not the University of Chicago. He's here from the Northwestern Feinberg School of Medicine, and he also works at the Rehabilitation Institute of Chicago. And it is my pleasure to introduce him for the second time. He was here at our very, very first family conference when we were in Skokie, which is also a suburb of Chicago. And I think he's risen up in the ranks a few places since then. He's now the chair of the Department of Physical Medicine, and he's going to be talking to us about recovery and rehabilitation after hemorrhage.
Thank you. Thank you, Connie, and thank you to all of you. It's really a pleasure and a treat to be here. I very much am pleased to be talking with you. I have a sizable amount of information to share, but I really was impressed by what I heard earlier by your questions and comments and thoughts. So if we can, I'm happy to be interrupted. If you have questions, I'm happy to take them along the way, or we can talk about them later. But most important, we want you to have an understanding of what's a very important topic, which is recovery and rehabilitation. As you heard, I'm at Northwestern University Feinberg School of Medicine. I'm chairman of the Department of Physical Medicine and Rehabilitation. I have a very active practice, predominantly people who have a variety of neurologic problems, including various forms of stroke, but also other kinds of trauma, other kinds of neurologic injuries. I'm also have a practice at the Rehabilitation Institute of Chicago, which is here in town. We fondly think of as the world's tallest rehabilitation center. It is a 180+ bed hospital focusing entirely on rehabilitation, a sizable number of whom have had problems with stroke and other neurologic deficits, but we also do a very sizable amount of research and teaching and advocacy and community activities related to people who have various forms of disabling conditions. And now we have a total of about 50 locations, mostly centered throughout the Midwest. We'll talk about stroke generally. It's a very important public health problem. Right now, probably there are more than 6 million people who've had a stroke in the United States, a sizable proportion of which have had cerebral hemorrhage as the cause of their stroke. What's most important to understand, especially for what we're talking about today, is that it's very clear that people with stroke now are living more in the early stages, and also more importantly beyond that in the longer period than ever before. It's very hard to do studies on this, but there's good evidence that the life expectancy has been extended, not only because of better early care immediately following the incident, but also we think because of more activities, more exercise, more involvement, more knowledge among people who've had the problem living in the community. And that also includes, by the way, more knowledge and awareness among clinicians, practitioners, people who take care of people who've had stroke. It's also very hard to get estimates of how many people who've actually had strokes actually have disabilities from the stroke. We think it's roughly about a half, but those studies vary enormously. And as you may know, it's one of the most common causes in many centers, the most common cause of an admission to a rehabilitation center. So many different kinds of things could happen. It's very important to understand there's not one specific single presentation. Some people think that they see one particular clinical problem in a patient and it must be from stroke, or think that a person who has a stroke absolutely must have that one particular problem. Doesn't work that way. There's a variety, a constellation of symptoms, lots of different kinds of symptoms that people present with. These are just some of them, familiar to probably most of you. Weakness or paralysis still being the most common, but again, not the only problem. Difficulty with language, difficulty with perception, difficulty with thinking, sometimes changes in behavior, which can include, by the way, not only impulsivity and aggressiveness, but for some people, apathy, and of course, emotional changes as well. All of those are common, and of course, many other problems as well. What's important to know, of course, is that these problems can persist, but they can persist for variable periods of time. And some of you might read about in the literature, you might read in either popular or publicly available literature, or in some of the scientific literature, that there's a set time when we should expect recovery. It doesn't work that way. All of us who work in this field know that we have patients who continue to improve much beyond the time that most of the studies, most of the so-called experts will tell you about. And that's a very important point to understand. This is a little bit complicated, but I mentioned this just to sort of bring home the point that there is recovery. These are figures of the different kinds of neurologic deficits and how they might recover. This is in the acute phase, which means immediately after the stroke. About 70 or 80% will have hemiparesis, which means weakness on one side. In the later stages, it's considerably less. It's less than half will have weakness. Hemianopia refers to difficulty with vision. You can see that it could be in about a quarter of patients in the early stages and probably about 1 in 10 or so in the later stages. Aphasia, which are the language problems, typically about a third of patients in the early stages. In the later stages, it's less, usually around 20% or so. So the point is that there is recovery, there is improvement over time. And as I said, despite the persistence of these impairments, most patients actually regain the ability to do their daily activities over time. This is again another complicated slide, but just to point out, if you look at patients in the early stages, for example, close to 80% need help with dressing, and in the later stages, this says 6 months or more, only about a third of people still need help. In the early stages, about 3/4 are unable to walk independently. In the later stages, an amazing 15% are unable to walk independently. This means that 85% or more, and we think the figures are actually better now, 85% or more of people following stroke are actually able to walk in the later stages. And the point is that what we see in the early stages immediately after the incident does not necessarily predict what will happen in the later stages. We expect to see considerable improvement, things in areas such as eating, going to the toilet, grooming, taking care of oneself, bladder and bowel continence as well. So why does this happen? Well, a big part of it happens because of natural recovery, that there is an ability of the brain and the systems involved to actually have some level of natural recovery. We also think that some of the improvement happens because of the effects of what we do as professionals and what you do as patients and families who've been through this. So the effects of what we do outside, separate from what the brain is doing independently on its own. This is just a sort of a relatively complicated story about what we think happens to promote natural recovery, that in the early stages following injury to the brain, that there's a reduced amount of cerebral edema, reduced amount of toxins and all the debris that happens from the either dead or dying nerve tissue, and that there's survival of some of the partially injured but not fully injured tissues. And later on, which is where we think we have an impact in exercise and activity and rehabilitation, later on, what we're learning is that a number of the nerve cells actually, which we thought had particular activity, a particular kind of process that they were involved in, they actually are able to take over some of the functions that they had not been doing before and that were missing because of the new onset of the stroke or the injury. Also, there's likely to be some sprouting of new nerves connections as well. We call that sprouting. So I write a fair amount on this topic, which is sort of what we do in rehabilitation. And there's sort of 5 different components of what we do in rehabilitation. The first is an important one. I do a sizable amount of research in this area. Prevent and recognize and treat when they happen some of the associated medical conditions. For example, some people with strokes have urinary tract infections, will have bladder and bowel problems, will have nutritional problems, will have blood clots, will have a number of other problems. Our job, all of our jobs, is to prevent them, recognize them when they happen, and treat them when they happen. But the main thing that happens in rehabilitation, as you know, is to train people to maximize their independence. Help them to be able to take care of themselves, do the day-to-day things for themselves. We think often about rehabilitation as being as much like going to school as it is being in a hospital or a healthcare facility, because we're training people how to do the day-to-day activities again. The third role is very important, which is to facilitate psychological and social adaptation and coping. And of course, that's not only for the person who's been affected by the problem, but also by the family members themselves. And likewise, to promote resuming, getting back into prior life roles. So some people are breadwinners, some people are caregivers, some people are get back to work, many people get back to school, to families. And of course, ultimately, all of these sort of can be summarized by enhancing quality of life. So we all have patients, we all deal with individuals who will say, you know, all this therapy is fine and good, but what I really want to do is I want to hold my grandchild on my lap again, or I want to play golf again, or I want to do those day-to-day things that made life happy and successful and fun and fulfilling and rewarding that we did before. So we focus on those. Now, just to kick that off, as I mentioned, there's a number of medical complications. This is just a small subset of them. I mentioned venous thromboembolism, which are blood clots, unfortunately fairly common. Pneumonias, other infections, of course, are common. Our job, as I said, is to prevent and treat these when they happen. And a big one, of course, and you're actively involved in this as well, is to prevent the recurrence of the problem as well. That's a significant part, that's an important component of the post-stroke, post-event care. What takes place in rehabilitation, though, involves a number of important activities. This is sort of the sort of philosophical approach to rehabilitation. Most importantly is that there are so many multi-dimensional problems that could take place. There's no way that one particular individual, no way that one particular physician or therapist or nurse or psychologist or anybody by him or herself, that includes family members, also can take care of it. So it's all done as a comprehensive interdisciplinary team, with the team members, very important, not working individually, but working collaboratively, interacting with each other, connecting, communicating with each other. So they have to be coordinated, they have to be holistic and comprehensive, and very important, they have to be goal-directed. So it's not just a matter of doing exercise just for the sake of doing exercise. It's very important that it be directed toward very specific day-to-day goals. Very important concept, which is to initiate the treatment early. And this often gets missed, unfortunately, by many clinicians, many hospitals, and by many families as well, is to not start the activation early. Our goal, our desire, our recommendation is that people be able to at least get up out of bed as soon as possible after the incident. If they could do more beyond just get out of bed, or at least dangle their legs or sit up, to be able to do things like walking, getting to the bathroom, going through those sorts of things, but also to be able to do some of the thinking and cognitive and language kinds of activities as well. Heavy emphasis, as I mentioned, on education and training, and of course a lot of it uses learning theory, which means that we are not only teaching people, but that we have to have what we call graded levels of difficulty. So we start with relatively simple techniques and activities, and then build it up. There's also attention to many of the psychological issues, involvement of the family. An important part of it is, of course, the need to recruit community resources, and heavy focus on not only functional activities, which means walking, bathing, going to the bathroom, feeding, dressing, those sorts of things, but also attention to quality of life issues. So these are, again, just a repetition of what some of the interventions are. And of course, we also use devices, and I think one of the biggest sort of interventions is ingenuity. So the creativity, of therapists, of nurses, doctors, but especially of patients and family members. So it's a very happy day when patients will contact me and say they created a new way to transfer in and out of a wheelchair, or they figured out a better way that they could get out of bed, or that they could walk or get to the bathroom. Many of our patients and family members will come up with those sort of creative ways. We encourage that. A big change that's happened in the past 5 to 10 years in rehabilitation is attention to intensity of training. So our rehabilitation program now looks very much like a health club, looks like a fitness center. So people are working, they are cranking. We actually have lots of treadmills, we have all sorts of special devices, but mostly what we have is we have people really working hard. And even though the equipment is important, but we have our physical therapists, other therapists who are actually pushing people, and not only sort of encouraging them, pushing them, but also measuring and monitoring. In fact, there's some very interesting recent evidence, recent studies that suggest that the number of steps, if you count the number of steps that a person gets in their rehabilitation program, it's a predictor of how many steps they will get out in the community. So a lot of the research that we do actually includes wearing pedometers, or what we call step activity monitors, applied to people's legs, and we'll count the number of steps that they get in the therapy program. So typically in most rehabilitation programs, people will get 200 to 300 steps per physical therapy session. And what we have been doing is, through using treadmills, through using trainers and physical therapists who push, we are now getting people to have 2,000 to 3,000 steps per physical therapy session. And then, as I said, we also have been putting these pedometers, step activity monitors, on people in the community, and found that actually the more steps that they got during the inpatient rehabilitation program, the more that they're walking out in the community, which is a sort of a wonderful outcome. And it points out the value of repetitions. Interestingly enough, we've now been applying this also to arm movement, and in fact, the number of arm movements actually correlates with the use of the arm in the community. And most recently, we've just in the past year or so, we've started applying this to people who have difficulty swallowing. So for what we call dysphagia or swallowing problems, we're finding that if you increase the number of swallows during a therapy session, we actually count the number of swallows done during a therapy session, that actually improves the ability to swallow later. So the point here is, this is all about intensity, it's all about practice, practice, practice. It's all about repetitions. And of course, a big part of what we do in rehabilitation is involving the family, and that involves not only counseling and dealing with some of the psychological issues, but also of course, education and training. So I want to take a bit of time to talk about many of the quality of life issues, which are very relevant for the people who've been through these experiences. These are just some of them listed here. Return to work is a very specific interest of ours. I just completed a 6-year federal grant on issues related to return to work after various types of stroke, including hemorrhagic stroke. I'll tell you, the statistics are unsatisfactory. So we're very happy when patients of ours are able to get back to work. We work very hard to help them get back to work. But the numbers are quite poor. Typically, there's all sorts of studies on this. Typically, the estimates vary from 11 to 85%, which doesn't tell you very much. The best studies probably suggest that about a third of all people following various types of stroke will be able to get back to work. Most of them who do so will do it relatively early, and most of them return back to their prior employer and may need to adjust the job duties or work hours, or have to take more breaks, or makes other kinds of accommodations. We're now very interested in retention, people being able to stay at the job, which is also been an issue. So it's very interesting, and many of you might be able to relate to this. I'm actually curious if you've had some experience with this. What we came to learn, all of us as professionals spend our time focusing on the patient, sometimes focusing on the family, but mostly focusing on the patient, helping them to acquire the skills, do what they need to get back to work. Of course, a big part of the return to work issue, a factor that's often neglected by professionals, is the employer, the quality, the accessibility, the understanding of the employer's him or herself. And it's very interesting because when we started focusing on the employer, of course, the first tendency is to focus on the leadership. We focus on the CEO or the president of companies or the vice presidents, the human resources departments. But what matters the most to our patients, to the people who are actually working, are the colleagues, the immediate colleagues, and of course the immediate supervisors as well. So although it may not sound very technical and medical, I have to say it was a great finding for us to figure out that the thing to do was to focus on the coworkers and the supervisors in order for us to help improve the work outcomes for our patients, to help them get back to work. So we're focusing heavily on them to the extent that we can. A lot of it relates to education, a lot of it relates to counseling. This is a very important, very relevant issue for people who've been through this experience. We also deal with the issues related to relationships and intimacy, and related to that, of course, sexuality. And there are actually a number of studies on sexual functioning following stroke. These are actually from some of the older studies, but the data from recent studies are actually fairly similar. So these are just some of the causes for restricted sexual function: fatigue, fear, pain, changes in sensation, reduced sensation. And I want to point out that there is nothing organic about the stroke, about the hemorrhage, about what's happened that by itself would contribute to having sexual dysfunction. So many of these issues are of course psychological. Many of them have to do with the quality of the relationship. Interestingly enough, for many people who've had the stroke at the time of labor and delivery, or at the time shortly afterwards, or even before, of course, child care and parenting are important. So we've actually developed modules to teach people, for example, how to change a diaper using one arm, how to chase children around in a wheelchair, how to do all the, many of the skills necessary for parenting. Again, not at all easy. This is actually an interesting brace device. It's actually used to apply to a wheelchair to help people who use wheelchairs to be able to hold and take care of a child. Some of you may have experience with this. Likewise, related to the day-to-day things like household chores. And this is another big one that we're very interested in, which is changes in the life roles. So we're very particular interest, because it comes up frequently, hear this often from patients, from family members, is when we recommend, or when it looks like a patient will need a caregiver to help with the day-to-day activities, oftentimes the spouse will want to do it or not. And it's actually a very important decision. And so we do a sizable amount of counseling, helping to discern which is appropriate for the particular family member. We have no specific direction, except on balance, we recommend, generally speaking, that the spouse maintain his or her role as spouse, as lover, as emotional support, and that if possible, have a professional or a different caregiver in. Now, oftentimes spouses object to that completely. They do not want a stranger in the house. They prefer to be doing all the personal kinds of activities and interactions themselves. We support that. We understand that. But we do take the time. We do spend a lot of time addressing that, and helping the family and the patient to understand what the best approach is for them. Driving is also a very relevant issue. We could probably spend the whole afternoon talking about this. I just want to highlight sort of a few main points. These are just some of the problems that could happen after stroke, after cerebral hemorrhage, that could cause difficulty with driving. It is usually not the physical problem. It is usually not arm or leg weakness. All those things we can compensate for it. There are arm controls. There are all sorts of adaptive controls on the car that we could use. The bigger issues are the cognitive and perceptual issues. So, as you know, to drive is actually a fairly complicated experience. The biggest issue, I think, is being able to keep 2 or 3 things in mind at the same time. So it's what we call split or divided attention. And of course, for many people who've had this experience, that is impaired. So we make specific recommendations about whether and to what extent driving should be permitted. These are some other things, of course, poor reflexes, impulsivity, problems with planning, being unable to change or shift according to the situation, awareness, of course, distractibility is a big one. Those sorts of things can be problems. So, which is not to say that people who've been through this should not drive, it's to say that there needs to be a very specific evaluation. And of course, socializing with friends. And this is a big one. It's very interesting. Many years ago, we did a study. We asked 100 people who were young who had a stroke. So the definition of young, anyone know the definition of young? Under 65, okay, what else? Definition of young is 15 years older than whatever you are. So we actually did a study just to sort of pick a date. We actually picked under 65. Although I'll tell you, there are many people who are older than 65 who have many of the characteristics, the kinds of things we're talking about related to activity, socializing, sexuality, driving, all those kinds of issues. But to pick a time, we picked under 65. We asked them what they would want from us as rehabilitation providers. And interestingly enough, we gave them lots of choices, probably 20 or 30 choices, a lot of the things we're talking about. The thing they wanted most was exercise, specifically aerobic fitness training. Aerobic fitness training was very interesting. So we actually spend a good deal of our time now promoting aerobic fitness for people with strokes, with cerebral hemorrhage, with other kinds of disabilities. And of course, some of that is formal organized sports. Some of it is being able to have access to a fitness center or a health club, and some of it is being able to do exercise or activity in the home environment. So there's a whole lot more to talk about related to the interventions and the kinds of things to focus on. I want to just get to a few other topics here relatively quickly. Just to highlight sort of what's expected after rehabilitation, after all that these people who've been through cerebral hemorrhages go through. Amazingly, it's estimated that 4 out of 5 are independent with mobility. That means walking, getting out of bed, moving around. 70% are able to do their personal care activities on their own, which is also quite striking. Unfortunately, of these individuals who have independent mobility, only less than half get outside the home very much. So we think this is a real problem. But this last one, I think, is actually the worst statistic. So the estimates, interestingly enough, for unemployment among people who've had various types of disabilities, including strokes, is 70% unemployment, which is, of course, outrageous and totally unacceptable. So as much as we've made progress on lots of these other areas, which is, of course, the basics, the bread and butter of what we do in rehabilitation, we have not spent enough time, I think, all of us as a community, dealing with return to work and maintaining work activities. So what affects the outcomes? Well, obviously the type and severity of the stroke itself. Clearly, as you know, with motivation and determination, one could fight through and get through a great deal of adversity, including the stroke event. Of course, ability to learn, the level of emotional and social support, very important. Medical associated conditions, coping and adaptability, but also a big one, we think, is being able to have the appropriate training, the appropriate rehabilitation. So there's always this question about, does it work? Does rehabilitation have an effect? I won't go through all the details. There are a sizable and growing number of studies that suggest it's effective, including this one was a sort of a combination, that's what meta-analysis means, a combination of a number of studies that said, interestingly enough, with rehabilitation, not only do you improve the function, meaning helping people to walk, bathe, go to the bathroom, take care of themselves, but you actually reduce mortality when compared to people who didn't go through rehabilitation. So very important finding. So people have less mortality when a number of the studies are combined. Why would that be? Well, of course, the people are more active, they advocate for themselves more, they're able to get in the community more, of course, do lots of other things that might help prevent the kinds of things that would contribute to death. Interestingly enough, of course, rehabilitation program had its greatest effects, personal care, mobility, walking, and visual spatial functions, which we talked about. But this one is sort of the take-home message, I think. Improvement more related to early initiation rather than the total duration. So many people, of course, want to continue their rehab for really, really long periods of time. While that may be important, the most important thing is starting it early, and that's according to several of the studies. This is from a clinical practice guideline, which basically means that a number of studies have been put together, used as evidence to create statements that professionals will then use to drive their practice. There is good evidence to show that intensive rehabilitation therapies delivered in short periods of time lead to faster recoveries and earlier hospital discharge. And so we always like to talk about, as I said, the earlier the better. Now clearly there's the issue of medical stability, there's the issue of associated medical problems, there's the issue of whether the stroke itself, the cerebral hemorrhage itself is stabilized. And of course, there's surgical considerations, lots of other issues, but the point is early is important. So I moved on quickly so we can talk a little bit about what's new. You're going to be learning a little bit later about some of the a number of new interventions, so I'm not going to spend a lot of time on those. I do just want to highlight a few of them, which are some of which have been in the news and the popular media, and some of which I want to mention because they're important conceptually. They actually bring out some really important points. So there's the concept of constraint-induced movement therapy. Some of you may have heard about that or read about this. So this is a really interesting concept. It was actually based on some animal studies, but we have lots of success with this in humans. And to be to be blunt about it, essentially it means tying up or constraining the functioning limb and forcing the individual to use the weak limb. It's called actually the forced use therapy. So the idea is that it comes from this concept that some of the weakness following stroke or other neurologic deficits, some of the weakness is not only from injury to the brain, but it's because of lack of use of the limb itself. It's very common, even people who have very subtle, mild weakness, very mild weakness where most of us might not even be able to tell, they have just a subconscious natural preference for using the stronger limb. And what that does is it just magnifies the weakness of the weak limb. So the concept is we tie up the stronger limb and then we force the use of the weaker limb. So this has actually been used quite a bit. It sounds kind of cruel almost in some ways, and so many patients actually don't like to do it. But what's been interesting about it is the finding that not only does it make the limb, can it potentially make the limb stronger, but we're finding changes in the brain. So those functional MRI scans that you saw earlier, right before lunch, we're finding that actually some of those actually change by forcing the use of the weaker limb. And it basically we're thinking that it improves some of the synapses, some of the functioning of the remaining nerve cells. So that's actually very exciting work, and it points out what I mentioned earlier about the importance of repetition and practice. That the point is that, as we like to say in rehab, use it or lose it. You know, you have to really force the use sometimes. Now, it turns out that only select patients will qualify for this. They have to have actually a certain minimum amount of movement to be able to have this be effective. So it's not just for everybody. So the concept here is the unaffected limb is secured in a splint or a sling, or tied behind the back or whatever. The restraint is worn. Actually, in the pure studies, it's actually 23 hours a day. In most centers actually use a modified version, restraining it for about 4 to 6 hours a day. There's actually a behavioral contract, so a person has to sign something that says that they agree to keep it on. Spend 90% of the waking hours in the restraint, worn for however many days. Every center has been doing this a little bit differently. But the other point of this is that it can't just be tying up the strong limb. It's actually all about using the weaker limb. So this is the hemiplegic limb, this is the weaker limb, and the person's using it for day-to-day activities, in this case pouring syrup on pancakes. We actually like to have people actually pick up coins, that's a common exercise, hold cards, so play cards with them, and hold a fork using the weaker limb, again, the day-to-day kinds of activities. So restrain the use of the less affected limb and practice the functional task. And this is what's been found: improve the speed of movement, improve the strength, improve the quality of movement. As I said, it also results in some changes in the brain. I think you're going to be talking a little bit later about some robotic training. We do lots of robotic research. This is very exciting. And the concept is not only to use the robotic to actually do the activity for the patient, but more importantly, to use the robotic for therapeutic purposes. And there's upper limb or arm robotic devices, which frankly look a whole lot like video games. So we have actually a whole laboratory at our hospital of just what looks like a video arcade, but it's really these are upper limb robotic devices. So the model typically is, some of you might have seen this, there's actually a video screen, and it's got a target on there, and the person holds onto a joystick, which is the robotic device, and the joystick's connected to the screen. What's interesting is that the person has to try to hit the screen, hit the target using the robotic device. What's important about the robotic device is not the mechanical joystick itself. It's that because it's robotic, it's computerized, and you could control, you could actually have the device do whatever it is you want it to do. So sometimes we set it up so that if it senses that the person is moving toward the target, it facilitates it. It helps the person move a little bit easier. Another one that we do, though, is that if it senses the person is moving toward the target, it pushes against them. So they have to push that much harder, which means that the person, him or herself, has to work that much harder. So there's all sorts of ways that we can program it. That's what's exciting about the robotic technology, is the ability to be able to not only strengthen, but also improve the direction and the quality of the movement. And the other thing is that because it's a robot, it can provide feedback, quantitative feedback about the mistakes, about the quality of the movement. And that's something that, although the therapists are very good at doing these sorts of things, they cannot do as well as the machines can on providing that quantitative feedback. What's also been exciting is the development of robotic devices to improve in walking. And there are now a large number of devices for walking. Some of these are over treadmill devices. This is actually a non-robotic treadmill with a harness that holds a person up. And basically when you off-weight or off-load the person, and some of you might have had this experience or have seen this, it actually makes it easier for the person to be able to tolerate being on the treadmill. We do a sizable amount of treadmill training. The problem with a lot of the treadmill training for people who have leg weakness is that the therapist, it actually takes two therapists to sit on the floor, literally on the floor, and actually move the limb if it's a weak limb. So that's where the robotic devices have been developed. This is basically what's called an exoskeleton or brace. That's mechanical, but it has motors right next to the hip and right next to the knee. And the motor actually moves the limb at the same speed as the treadmill is moving. So we have this nice experience of actually having a person held up by a harness, a little hard to see here, held up by a harness, and the motor's actually moving the limb while the treadmill is moving. Turns out that while this could be very valuable for some people, maybe some of you might have seen this or experienced it or had family members who've experienced it, turns out that although we've been historically very excited about this work, most recently what we're finding is if you have the robot doing too much of the work, it actually works against the patient, because we want the patient to do the work. Again, as I mentioned, it's all about repetition and practice and intensity. So if the device, if the machine is doing too much of the walking, that becomes actually a problem because the patient's not doing enough, him or herself. So there's a number of pros and cons about using the what's called robotic-assisted body weight supported treadmill training. That's what that means. So we've been very interested in this concept about how humans interact with robots. And so we actually created a brand new robotic device. There's only about half a dozen of these in existence now. But this is an interesting device that's actually over ground. The person is held up by a harness. The harness actually was developed by the company that makes harnesses for Cirque du Soleil, if you've ever seen them. So we know that it's a good quality harness. But more importantly is actually the robot has this software in here that follows the person around. So if the person makes a sudden move, the robot knows to move. It's actually got wheels on the bottom. And it's nice that it's over ground because it allows you to go outside with this. So there's actually a machine is following the patient. This is the physical therapist here. And these are the wheels here. So the idea, though, which is hard to tell just by looking at a still picture, the idea is that if it senses the person is moving just a little bit to the right, the machine will move that way too. So it's all about the sensors and the ability of the machine to sort of track it and follow what the patient's doing. I mentioned the harness, but this is the other thing about it. If it senses the patient's about to fall, it catches the patient midair. So that's a great thing because, of course, many of you know falls are a very important problem. We see them. We work very hard to prevent them. But in many ways, we have to sort of push people to the point where they're just about to fall, so we make sure that we know their limits and make sure that they're actually working hard enough. So having something where we can protect the patient from falling by using a harness that actually senses that they're about to fall is really very valuable. It also allows people to feel freer to do more activities, to take more risks and try many of these things out. There's also a common question about whether medications could be effective for recovery after stroke. Right now, these are disappointing. There's a number that have been tried. There's a number of trials that we are just now getting involved in again. But up to now, there's not been good satisfactory results. We are also working heavily with what's called neuromodulation, which means electrical stimulation of the brain and also magnetic stimulation of the brain. Electrical stimulation of the brain is actually a very exciting area. I just want to highlight just a few things about what's called transcranial, which means across the skull magnetic stimulation. This is non-invasive. So you basically take a low dose of magnetic stimulation, which is given by this machine. This is the coil that gets placed right over the person's head. Basically click a button, person hears a click and then gets a jolt. Doesn't feel like a jolt at all, but what can happen depending on how it's structured is it may actually help to promote a twitch or a movement of the limb on the opposite side. So what's been very interesting is that there's very good evidence that it's not going to be the coil or the magnetic stimulation alone that's relevant, but it's going to be the magnetic stimulation together with exercise and activity. That's where we think the best progress, the best success is going to take place. We call it paired associative stimulation. So I just want to sort of finish up with sort of how our institution's actually applying this. We are in the process of building a brand new rehabilitation hospital, a 240-bed rehabilitation research hospital, which will combine research and patient care. To do that, we actually have just opened a brand new unit, which will be sort of the practice for all the concepts we'll move into the new hospital. We call it the Patient Recovery Unit. It has what we call the Ability Lab, which is not only a therapy gym, but also a research lab all at the same time. So we have researchers together with clinicians, with therapists interacting with patients. So we have a number of devices. This is actually an advanced upper limb robotic device where a person has a target. They're actually attached to this robotic device and the person's actually trying to hit a target on the screen. We have advanced robotic treadmill trainers. And mostly, of course, what we have are professionals who are used to mostly working with intensity and pushing patients. So a big question conceptually is that, because we have so much specialized equipment, the question is it about the equipment or is it about the patient-therapist training interaction? And while the equipment is very important, it is very important, it's also extremely important to understand that it's really about the intensity of training, it's about the interaction with the professionals, where technology can enable and support, but not replace what the professionals do. So just to sort of summarize, there is an emphasis on technology, but a special emphasis on use of interdisciplinary teams, heavy focus on methods to improve function, on some and growing function emphasis on the neurologic deficit. A lot of these are practical interventions, but also probably have some basic science implications. Again, big emphasis on intensity and repetition. What we're very impressed by, though, is the likelihood that it's not going to be just robots. It's not going to be just exercise. It's going to probably be some combination. We like to think of it as a cocktail that's going to make a big difference for these patients. In fact, it may be that the best use of medications, of electrical stimulation, is to sort of prime the brain to be able to take some of the positive effects of exercise, activity, robotic devices best. Likewise, for interventions using cell therapies, stem cells and genetic therapy. We are now getting involved with stem cell studies. Interestingly enough, again, likewise, we think that it's not just a matter of injecting a stem cell cocktail, stem cell soup into the brain or into the blood that's going to make a difference. It's going to be having the stem cells together with exercise, maybe enhanced by using electrical stimulation or medications or certain other kinds of interventions. So the point is that it's about the combination of strategies. With that, I'll close and thank you for your attention.
If you have some questions, please write them out and we'll collect them. And I'm going to ask a couple questions first.
Sure.
My first question is the overground harness frame thing. Are there indications for which it's not appropriate? So we have a lot of folks that have ataxia. We have folks that have complete paralysis. How far in level of functioning do you have to be in order to make it work?
Yeah, it's a good question. So the question was about when do you actually use that device that is an overground robot that follows the individual. So a lot of this is actually still in development. We don't actually know. We think that there's probably a role for when to use a treadmill, when to use a robot, when to use an overground robot. There is right now no particular patient that this is not appropriate for. A patient obviously has to be medically stable and tolerate the upright position. That's probably a big part of it. There's still value to using the treadmill. So we're actually very big fans of treadmill as well. But the short answer is we don't know the sort of where the place in the whole sort of structure of rehabilitation this is going to fit.
And then my second question is, I'm very connected to the parents community in our group, and so we have kids who are becoming teenagers who may not necessarily have physical deficits but have enough attention cognitive issues that there's a question about whether or not they should be learning to drive. Is that the same? Are the evaluations for people who have already a history of driving and know how to do it but just got a little setback versus someone who doesn't know even the beginnings of driving? Are those separate paths in the evaluation process?
Yeah, it's a good question. The question was about driving among teenagers and how to do the assessment. Well, so it's that you could argue that children have more plastic brains that actually will absorb more, take in more. Big part of it has to do with ability to learn, and there's different kinds of learning, and a new learning is actually different than memory of old events and has a different part of the brain involved, different types of function. So most likely, the sort of answer to that has to do with being able to test people, test the children, test the adults for what their capabilities are.
Great. And then the next question is more on the psychological side of things. How does a therapist overcome a person's mental barriers to therapy? For instance, a person says, I hurt worse after therapy than before, so I'm not going to do it anymore.
Good question about sort of how to overcome the mental barriers. So not all, but most therapists and most people who do this are used to and have experience with and oftentimes trained in how best to motivate, how to stimulate activity among the patient. At the end of the day, it's really up to the patient because it's all about hard work. You know, this is not something that's done to the patient, but done with the patient. So we need the patient's active engagement and participation. So most therapists are able to sort of, my view is everyone has a hook, and our job as professionals is to figure out what the hook is. What is it that turns them on, what motivates them, and work very hard to use that as a motivator. Interestingly enough, some people are heavily motivated by the potential outcome, by achieving the goal, and so we work toward that by having them focus on the goal. Some people are more motivated by the experience itself, and so we try to make it fun and interesting and find out what their interests are, what they want to do, as I said, what their particular hook is. And so a big part of what we do in the assessment period is figure out what is it that makes it work. So the pain issue is an interesting one. So pain can be a major limitation in the therapy experience. Sometimes the pain that happens after therapy is real, and it's not just a matter of sort of not wanting to do the therapy or not being motivated. And so the idea is to find out, figure out what the best exercise movement pattern will be that to help reduce the pain. A lot of times we use special strategies, like we have the patient take pain medicines a half hour or 45 minutes before they're about to start their therapy. Sometimes we have them, unfortunately, sometimes it's no more scientific than trial and error. Again, just to sort of figure out what is the exercise, what is the movement approach that will be best for them without any pain. So there's no one solid answer. A lot of it is really just testing it out.
And then the last question, I'm going to kind of rephrase this because I'm not sure I understand how it's written here, but so you've been talking about stroke and hemorrhagic stroke, and the folks in this room have cerebral cavernous malformations, and I think there's some confusion about whether everything you've spoken about is applicable to them, or if there's some difference that comes with CCM that needs to be taken into account. Did I get that question right for whoever asked it?
Yeah. I'm glad you asked. I should be sort of clear and very focused. The issues here relate to people who predominantly have had a bleed and not have had the CCM itself. People who have had a CCM and then had a bleed, it may have caused some of these problems, in which case a lot of these things are applicable. For people who have not had a bleed that caused these problems, it's not relevant. Does that help?
I think so. I think
Okay.
so. The person who asked that question, raise your hand. Okay, and did that answer the question?
Yes.
Okay. All right. Are there any other questions before?
Okay, thank you.
Okay, thank you.